Muy buenos días. Good morning, everyone. Soy Pedro Abedillo, asesor regional de tuberculosis de la Organización Panamericana de la Salud en la oficina de Washington, D.C. Quisiera darles la bienvenida a todos y todas a esta reunión regional virtual organizada por la Organización Panamericana de la Salud y titulada El papel de la radiografía en la búsqueda activa de tuberculosis. Queremos recordarles que tenemos traducción simultánea a dos idiomas, a español e inglés, y ustedes pueden elegir su idioma de preferencia utilizando el icono del globo que está en la parte inferior de sus pantallas. And for this webinar, we will have simultaneous translation in English and in Spanish. And you can see at the bottom of your screen, you will see a globe, and if you click on the interpretation globe, you can select the language of your choice. También comentarles que hoy tenemos unos presentadores de excepción que más adelante van a ser presentados por mi colega Pablo Jiménez, y comentarles que esta sesión va a ser grabada y va a ser compartida con ustedes y también va a ser incluida en nuestra página web. De igual manera, le vamos a compartir un enlace donde pueden acceder a las presentaciones de este webinar y también de los webinars previos. De momento las presentaciones de hoy solo van a estar en inglés, pero en los próximos días vamos a facilitar su traducción al español. Recordar también que esta es una sesión virtual organizada en conjunto con Pablo Jiménez, que es asesor de salud radiológica en el Departamento de la OPS de Innovación y Tecnologías en Salud, y saben que este webinar forma parte de las series de webinarios que estamos realizando para apoyar la expansión del uso de la radiografía para el tamizaje de la tuberculosis. Saben que la radiografía se ha reposicionado como una herramienta clave para el tamizaje de la tuberculosis, y que en combinación con los software de inteligencia artificial para la lectura automatizada pueden facilitar su expansión y el acceso a estas tecnologías. En los webinars previos hemos hablado de la necesidad de hacer un mapeo de los equipos de radiología que existen en los países actualmente y analizar las necesidades que existen para la expansión de esta tecnología, iniciando por supuesto con las zonas de mayor carga de tuberculosis, enfocándose en el uso prioritario para las poblaciones vulnerables, pero viéndolo como una oportunidad para fortalecer los servicios de salud de una forma más integral y no solo para tuberculosis, ¿no? Y este mapeo de los equipos que existen, de la capacidad instalada, pero también el mapeo de las necesidades para su expansión, sabemos que podemos ver que tenemos equipos ya existentes que pueden adaptarse, digitalizarse, y también tenemos que ver las necesidades de nuevos equipos, ¿no? Hemos hablado en webinars previos que no solo tenemos las nuevas tecnologías o los equipos de ultraportátiles que muchos países están adquiriendo, que también tenemos las unidades estacionarias, los equipos portátiles que nos pueden permitir fortalecer la red de servicios, y con este webinar queremos seguir profundizando en esos conceptos básicos que nos permitan seguir entendiendo estas tecnologías, las diferentes tecnologías que existen, su comparación, su utilidad y qué conceptos tenemos que tener en cuenta para su selección. Entonces, yo con esto solo darle la bienvenida y las gracias de antemano a todos los panelistas de excepción que vamos a tener, y me gustaría dar paso al doctor Pablo Jiménez, quien va a dar también las palabras de bienvenida y hará la introducción de los participantes. Adelante, Pablo, por favor.
Muchas gracias, Pedro. Buenos días a todos, a todas, otra vez en este webinar en apoyo a este tema tan relevante, tan importante como es la eliminación de la tuberculosis. Como bien decía Pedro, el enfoque de hoy va a estar centrado en el papel que juega la radiología en el control de la tuberculosis. Como sabemos, tiene un papel, pero también tiene una serie de retos a la hora de implementarla. Hemos hablado en webinarios previos de los aspectos de regulación, de los riesgos de la radiación, de una serie de cuestiones que deben cumplirse para poder tener las autorizaciones a nivel nacional a la hora de usar equipos de radiología. Hoy queremos complementar con otro de los retos que sabemos que tienen algunos de los países y que con un panel importante que tenemos hoy para tocar estos temas. Están relacionados, por un lado, con la tecnología en sí. Es importante conocer qué tipo de tecnología hay, qué ventajas, qué inconvenientes, qué retos, porque lógicamente el entorno puede ser importante a la hora luego también de tomar decisiones en qué incorporar y cómo. También vamos a hablar de otro tema que es el uso. No solamente es la tecnología, pero también es relevante poderla usar, y normalmente el que usa los equipos, estos equipos suelen ser tecnólogos o radiógrafos, depende del país, pero es importante que la tecnología sola no hace nada. Necesitamos personas, necesitamos gente que sea capaz de hacer las exploraciones adecuadamente. Entonces también es otro tema que vamos a tratar hoy. Y también, por último, es muy relevante también que lo que produce, que son imágenes médicas, sean de la suficiente calidad como para el objetivo, o bien para que sirvan al software. Si está basado en sistemas automáticos o de inteligencia artificial, tiene que tener la suficiente calidad para que el número de falsos positivos o negativos sea lo menor posible, y también, o en caso de que sea la vista de un experto, que también tenga esa suficiente calidad. Entonces también hablaremos un poco también del punto de vista de la calidad de imagen de los distintos sistemas. Eso es un poquito el panorama que tenemos preparado para hoy. Para ello tenemos tres, como digo, tres expertos a los cuales agradecemos muchísimo su dedicación y su tiempo. Primero es doctor Benjamin Musal, que es un físico médico del Departamento de Radiología de Henry Ford Hospital en Detroit, Michigan. El segundo panelista que nos hablará es, o lo voy introduciendo después según vaya empezando, si os parece. So, uh, maybe Benjamin, maybe you can start, and I will be introducing one of you at the time, if you prefer, maybe it could be better. So thank you, Benjamin, for your time, dedication, and please just prepare your presentation as you please. Ah, yeah, here you are. Okay, go ahead.
Thank you. You can hear me?
Yes, yes, we can hear you. Yeah.
Okay. Thank you all for having me. Today, I will be talking about the use of X-ray in tuberculosis control. I will come from a technical perspective, understanding the X-ray technology and the environment in which we use it. I'll begin my presentation today with an introduction to the basic principles of an X-ray and how they pertain to the chest X-ray. I'll then explain the different parts of the X-ray technology and the environment in which we use it. Specifically, how do we protect people from the radiation that we're using? Afterwards, I will connect these to the X-ray types, portable and fixed, and how you might select one of these units for use in your clinic or for your situation. And then I will finish up talking briefly about my profession, which is not practiced everywhere in the world. So to begin, X-ray radiation is a form of electromagnetic radiation, just like the visible light that we see with our eyes. However, X-rays are much higher energy than that visible light. And it's this energy that determines the behavior of the electromagnetic radiation. X-rays have enough energy to interact and create ions. For this reason, we call them ionizing radiation. And when they interact in our body, these ions can damage our DNA, and this can create a risk of a later cancer. Now, this risk is relatively small, and because X-ray images are so useful, we consider this risk to be worth it. Now, another component of this energy is that for a single particle of this electromagnetic radiation, which we call a photon, that particle, if it has a higher energy, it is less likely to interact when it goes through matter. For example, light has a lower energy, would stop at the surface of some matter, but some X-rays will travel through matter. In the clinic, when we use X-rays, we pick energies such that some X-rays will penetrate through the patient, and then some X-rays will interact within the patient. And by doing this, we can see what is inside of the patient. The way this works in the context of acquiring a radiograph, taking an X-ray, we first begin by generating X-rays. We shape the X-ray beam so that it falls on the useful area of the patient, the area we wish to see. When we first create this beam, it's very uniform, very smooth. However, after it passes through the patient, some of the x-rays are stopped. These x-rays are stopped by what is inside the patient. So what we have created in the beam is an image of the inside of the patient. We can't see these x-rays with our eyes, so we use a detector to capture this image, and then we can transmit it for interpretation, so we can see what is going on inside the patient. When we acquire one image, we take one x-ray exposure. So we have the patient positioned, we've prepared our machine's settings, and then we very quickly turn the x-ray beam on and off. And we've programmed the machine to use the right x-ray technique to have the right settings for the right energy of x-rays and the right amount of x-rays. One part of this x-ray technique is called the KV. This KV is the x-ray potential. So this controls the x-ray energies that we're using during our acquisition. If we have a high KV, we have high energy, and this is more penetrating. So in order to get enough x-rays through the patient and create an image, because it's more penetrating, we have less radiation dose. However, when we use high KV, we can't see bone as well. If we use low KV, the energies are lower, it is less penetrating. So in order to get more radiation through the patient, we need more x-rays. However, bones will be more visible. For the task of looking at tuberculosis, when we take a chest x-ray, we use high KV. And the reason we do this, well, one of the reasons, is so that we can best show the lung behind the ribs since they overlap with one another. I have some example x-rays of a patient from my hospital. This lady had 2 x-rays of her chest. They were taken very close to one another. However, for one of them, they used a low KV because they wanted to look at this patient's spine. And another one, they used a high KV because they wanted to look at the lung. If we look at these zoomed in sections, we can see that on the low KV, that the ribs are very bright, and then the lung behind it is very dark. However, for the higher KV, they're more similar, and we're able to see the lung very well behind the ribs. So for this x-ray technique, when we get a chest, we use a relatively high KV, 110 or 120 KV. For bone, we would use a little bit lower. The other component of an x-ray technique is the MAS. So we need enough x-rays to create a good image, and the way we can consider the total number of x-rays is the MAS. And this is the product of the tube current, which is how quickly we produce x-rays, the rate of x-ray production, as well as the exposure time, which is from the start of the x-ray, how long do we keep it turned on? So in this example, how quickly we produce and then how long we turn it on is how long we would count while we total up the x-rays. And we can see that with enough x-rays, we can get enough of an image for interpretation. If a patient is thicker, we need more x-rays in order to penetrate them and create an image on the other side. A thin patient wouldn't need as much. And for a chest x-ray, we will adjust this MAS to the patient thickness. So that's how we get an x-ray, the basics of it, how we program a technique. So I would like to talk about how the x-ray machines can support this x-ray exam. There are 4 categories of functions that are provided by the x-ray machine. The first is to create an x-ray source and control it. This will give us the x-ray beam with the correct technique. The next is to support the x-ray exam and align the geometry. So we can position the patient, align the x-ray beam to scan the right area of the patient. Next, we capture the image using our detector. And finally, there's some sort of data management where the image that we have on the detector is transferred to another system where we can use it. So at the beginning, we have the x-ray tube. This is where we actually generate x-rays for imaging. The way this works is we have a difference in electric potential that will pull electrons from a cathode so that they collide with an anode. So this electric potential pulls the electrons off and they're accelerated to hit one spot on the anode. When they hit the anode, through some physics interactions, they create x-rays. And these are the x-rays that we use to acquire our x-ray images. Now, it's from this tube that our earlier, the earlier techniques settings are derived. So that amount of acceleration in the tube is the kilovoltage. That's the amount of electric potential, which determines the energy of our X-rays. And then how many electrons we send from the cathode to anode per time, how quickly, what is the rate, is the milliamperes. So this is where those earlier technique factors are derived from. These are the settings of our X-ray tube. Now, when we use the tube, as these electrons go from the cathode and collide with the anode, they create a lot of heat within the anode. So we have to have technology to prevent the anode from melting. One way that we handle this is we connect the anode to a system that will transfer heat away from the anode and cool it down. And then another way to approach this is to rotate the anode. So the electrons are always coming from the cathode and hitting a point here. However, we spin the anode around very quickly, many thousands of times per second. And this can spread heat across the surface of the anode and prevent melting. So this is how we handle heat in the X-ray. However, different X-ray systems, different models of X-ray have handled this in different, they use different sets of technologies. So some systems have more heat capacity than others. This means that they can take more images without having to wait for cooling to prevent melting. How long you should wait also depends on what X-ray technique you're using. And one note I think is important to point out, some X-ray systems do not have a rotating anode. So all of the heat is on one portion of this anode. It doesn't spread it out across one surface. And because of this, they have much lower heat capacity. You cannot take X-rays as quickly with these systems. But of course, maybe you don't need as much heat capacity, so they're still useful in some situations. The last thing I will tell you about the X-ray tube is the housing. So the cathode and anode are contained within a piece of glass, and that glass it is a vacuum. There's no gas inside of it. This way the electrons can travel freely from the cathode to the anode. It also has to have a power source to generate the voltage difference. Different systems can have different power requirements, and some systems are able to run on battery, specifically portable and ultra-portable systems. And last of all, when we create X-rays at the anode, they actually go in all directions, but we use a cage, a lead lining to prevent the X-rays from going everywhere, and we only have one small window that allows the useful beam to come. One thing I will point out, even though we have this lead shielding around the tube, there is still some X-rays that can leak through. We do not stop all of them. The last thing I will talk about is these controls, the interface that we use to control the X-ray technique. Here's an example of one here. The technologist, while they take the X-ray, can program in the X-ray technique. They use this device called a dead man switch to start the exposure. They push a button and hold it, and when the machine has fulfilled the technique, the exposure will automatically stop. We call this a dead man switch because you have to use pressure with your thumb. So a dead man could not use it. And then the last thing I would mention, for controlling the X-ray technique, there's a technology called automatic exposure control. So rather than picking an MAS that we think is good for the patient, we have another set of detectors behind the patient, and they listen to the radiation as you're taking the X-ray, and once they have enough to make an image, they stop automatically. So this is really nice because it can adjust the X-ray technique automatically to the patient's size. However, only fixed X-rays have AEC, and not all of them have it. In the future, portable X-rays will also have AEC, but this technology is still under development. So moving on from the X-ray source and controls, we have the geometry and support that we use to align the X-ray field for imaging. We have these large devices, which the tube is mounted to. We call that the gantry. We can shift them around and adjust where the tube is. And then we have the patient supported by, right here, we have a chest bucky, we call this, or a table that they can lay on. And this would be for the fixed X-ray units. If you have a portable X-ray unit, you only have a gantry. So you have to be more creative and use a hospital bed or other items to align the X-ray field. You can't see it because it's behind this lady, but attached to the front of the X-ray tube, the source, we also have a collimator. These collimator are pieces of lead that come in and restrict the X-ray beam just to the area we're interested in. So that's this area here that the X-ray beam is restricted by the collimator, the pieces of lead. Now, in order to make this plan, this is a light field that is projected from the collimator. This is a clever idea. There's a light bulb inside of the collimator and a mirror. So the light that comes out of the collimator matches the X-rays that will later come out. So it allows you to plan the X-ray image. So after we've created the beam and collimated it correctly, we will detect it on the other side of the patient. All modern radiography systems use digital detectors. This is a type of semiconductor technology that directly converts X-rays into electrical signal, which can become our image. These digital detectors are flat panels, and they have an array of many different detectors, thousands of them, and these are extremely small. They're less than 1 millimeter per side. They're very fragile, this technology. Some vendors, the people selling the X-rays, they have something called drop height resistance. In theory, this is how high you can drop a detector from without it breaking. But we should never test this. They're very delicate, but maybe this can give us some confidence with how robust the detector is. So a higher drop height resistance would mean less fragile. Maybe we feel more comfortable using this detector in our clinic. Finally, these detectors do require electrical power. Very frequently, they're battery powered, and then they send their data via a Wi-Fi connection. It's very good to have several batteries in your clinic to power these detectors so that you can keep using it. Another thing I will mention about detection is the grid technology. So while we're imaging the patient, I said earlier that some of the X-rays don't make it through the patient. They're stopped by what's inside the patient. Now, some of these interact by scattering. So in this diagram, we have 4 X-rays coming from the source and going to our detector. X-rays A and C are being scattered within the patient. So these aren't from the primary beam, and these scattered X-rays can cover up parts of the image from the primary beam, since we don't know where the scattered X-rays are coming from in the patient. So we can use this technology called a grid. It has lines of lead, and X-rays that did not interact, did not scatter in the patient, can continue through the grid without getting blocked by the lead. However, these scattered X-rays get blocked by the lead. So a grid's a useful technology for improving the image quality. If there's not that much scatter, a grid may not be very useful. If there's very thin anatomy, the arm or a leg, or thin patients like children, maybe a grid is not necessary. Grids have to be aligned with the primary beam. So if you're in a situation where you're imaging very quickly and you don't want to worry about alignment as much, you might avoid using a grid for convenience. The last functionality provided by an X-ray system is the data management. So this is essentially software that manages the data before and after acquiring the X-ray. And a modern system will manage the patients before we image them. This is called a modality work list. So it's just a list of patients and the X-rays they need. This facilitates communication between the doctor and the technologist so they know what exams they need to take. And then after we image at the radiology modality, this would be our X-ray machine. These images are sent to a database, and this is where we can store the images and view them later. The terminology for this is a PAC system, picture and archiving communication system. And the last thing I will mention about data management is that X-ray systems send data in a standard file type, a standard data format, which is called DICOM, and that abbreviation is here. So we talked about how X-rays are acquired and the technology underlying them. I'd like to talk now about the environment in which we use them and how we protect people from the radiation. So I mentioned at the beginning that radiation does carry a risk of later cancer when we use it if it causes a harmful mutation, and that we must balance this when we're acquiring an X-ray image. If we're thinking about the risk of ionizing radiation to the patient, we should consider the usefulness of the exam versus how much risk there is from the exam. So in our lives, we naturally receive radiation from background sources, from the earth we walk on, from the air we breathe. from the sky we live under. Now, these background radiation sources, if we think about how much radiation we get every day naturally, just by living, one chest x-ray is equivalent to 10 days of living, 10 days of background radiation. So this is a pretty small amount, and the x-ray is very useful. So there are many cases where we think the use of x-ray is justified for the patient. However, let's consider the environment around the patient as well. So when we're taking an x-ray, I mentioned that some of the x-ray is scattered from the patient and that some of the x-rays also leak from the tube, from the housing of the tube. We call these two types of radiation secondary radiation. Now, these are much lower than the primary beam that we use to image the patient. However, if we keep scanning many patients and there's a lot of secondary radiation going to areas nearby, people nearby can get some radiation dose from the secondary radiation. So we want to pursue radiation protection. Those people nearby, they don't need the radiation to get an image of themselves. It's just from where they're working. So we want to lower that as much as we can. And we'll use radiation protection for this. We have three famous tools for radiation protection. They are time, distance, and shielding. If we want to talk about time, if we have one person who keeps taking x-rays and they're getting the secondary radiation from it, if we instead have two people so that each person is only working half the time with the x-ray, we can have both of their doses. This is how we can manipulate time. If we have the time near an x-ray, we can have the dose to that person. So having personnel take turns while taking x-rays is one way to manage this. When we're using distance, distance is even more effective from a mathematical perspective. If someone is taking x-rays and they're nearby and we can have them move twice as far away, they can move from 1 meter to 2 meters away. This actually quarters their dose. It divides it by 4. So distance is extremely effective for reducing dose to people nearby. Practically, we want to stand as far away as we can from the machine and the patient during the exposure. And when we design our clinic and we use an x-ray system, we want to design our clinic so that people are far away from these sources of secondary radiation. Last, shielding. We can block this radiation with lead and also somewhat with concrete. The ways we can practically use this, if we have someone inside of the room or nearby the x-ray working with it, we can use these portable lead shields or aprons with lead inside of them to block the secondary radiation. These usually block about 90% of the secondary radiation. And then if we want to take a more thorough measure, we can add lead to the walls of the room that we're using the x-ray in. And depending on how much lead, this can block 95% or even more of the radiation. Now, to calculate how much lead is needed for a wall is a bit of an elaborate calculation. There are methods for doing this, and I'll display a resource at the end of my presentation that can help guide some of these calculations. There's one principle underlying all of our radiation protection efforts for this use environment of the X-ray, and that's the ALARA principle. This stands for as low as reasonably achievable. This means that we take efforts to protect people from radiation, and any opportunity that is convenient and cost-effective, we will always use that method as well. We always get it as low as we can using reasonable methods. And I will go back to one thing. Distance is so effective. If we're thinking about secondary scatter radiation, if we move from 1 meter to 4 meters away from the source, we can have a 94% reduction in the radiation. If we would have to wear an extremely heavy 0.5 millimeter equivalent lead apron, which is a very heavy piece of clothing to wear to get an equivalent reduction at 1 meter. So for free and by walking farther away, we can get a very good reduction in radiation dose. If you want to use x-rays in a field operation, say you're visiting a town that people are living in, we should avoid sending up these x-rays near people. Maybe we can find some open space where no people are working or living nearby. Maybe that space is against water. The area we're taking x-rays, we can restrict it, maybe with something like this setup. And then it could also be useful to use elevation to create more distance, because distance is so effective for reducing radiation dose. Maybe we could take it on top of a hill, down in a valley. These are some options. So the last thing I will mention is the X-ray types and how we might select them. So we have fixed X-rays, which are installed in one room, a portable X-ray, which we can roll around a hospital, and an ultra-portable X-ray, which can go anywhere. From a technical perspective, fixed X-rays are very powerful. We can get images very quickly with less blurring, and they have very good heat management. So we can take a lot of X-rays before overheating. For portable and ultra-portable, they are not as powerful. They cannot manage heat as well. So they're still capable of the same exams, but we cannot get very fast, reliable imaging with them as much as we can with fixed. And with fixed, we can arrange the patient with a very consistent geometry. However, we can't move it around. It doesn't offer the flexibility that portable and ultra-portable does. They can go around the hospital. They can go anywhere. For a fixed X-ray, we do have to have a consistent, strong source of electrical power, whereas the ultra-portable X-ray and portable would be battery powered. And then with fixed, we can have the automatic exposure control technology, which we do not have for the portable and ultra-portable. From a radiation safety perspective, fixed, we can pick a good room to have it in near the edge of the hospital, away from people, and we can add shielding to that room. For a portable, if we're moving it around the hospital, we might not need to provide shielding since it's always in different places and it's not always next to the same person. For ultra portables, we would set up in an isolated space. And then for both of these units, we would ask the person using them to stand away from them. Now, one thing I will say, if you buy any X-ray unit and you're always using it in the same room and there's people nearby, then you probably need shielding. Even if it is technically a portable or ultra portable, if you keep it in the same place, you should shield it. Now, I'm running late on time. So if you want to select a particular machine, find out what imaging your clinic will do, search the market, find what is compatible with your needs and that your clinic can support, and then get information about the unit. And I would really, really highly recommend that if you want to buy something, find someone who's already using it and talk to them on the phone and find out their experience. That's my strongest advice for selecting an X-ray unit that I present today. And then once you have a lot of information, pick the best option that fits you. In my presentation, I also have some more slides about specific questions you could ask for picking an X-ray unit. I'll go over these quickly. Again, if you can talk to someone who's using an X-ray, that's very useful. And here's my summary. X-rays are high energy radiation we use to image patients. We have X-ray machines that support this imaging. Ionizing radiation can be harmful, but we can use radiation protection to protect ourselves from the radiation. And then I had some advice on how to best select an X-ray machine that meets your needs. So I am a medical physicist. My profession is not practiced everywhere, but medical imaging is based on physics, and it can be useful to have a physicist in the hospital to ensure the safe, effective operation of machines. There's some professional pathways around the world that can encourage people into this. If you know someone who is good at math and you think they might be interested in these kinds of problems, I would encourage them to look these places up and maybe get some knowledge and do some medical physics. Thank you very much to the PAHO personnel for asking me to be here and supporting my presentation. Here are a few resources that would be relevant to what I presented, and thank you all. Muchas gracias.
No, thank you. Muchas gracias, Benjamin. Gracias a ti por tu tiempo, tu dedicación y por refrescarnos un poquito y actualizar a algunas personas, unos más, otros menos, supongo, en temas tan relevantes, desde cómo se forma la imagen, la física que hay detrás, los elementos que hay que considerar, la practicabilidad y también un poco por revisar un poquito las tecnologías que hay, los pros and cons, consideraciones que hay que tener a la hora de incorporar en función del entorno, ¿no? Creo que es muy, muy importante y muy relevante. Vamos a las personas, por favor, que tengan preguntas o cuestiones, quizás las vamos a dejar, si os parece, al final y las vamos a intentar responder después de las tres presentaciones, si os parece bien la forma de proceder. Entonces, de esta manera, entonces invitamos al siguiente panelista de hoy, que también le queremos agradecer su dedicación y compartir con nosotros su experiencia. Es Suleiman Bagolun, is Assistant Professor at the Imaging Science Department at College of Health Science at Rush University in Chicago, Illinois, United States. he's an has been researching in areas that include, but not limited to, quality improvement in diagnostic imaging and exploring the effects of climate and social determinants on health on type 2 diabetes care management, among others. So, Sulaiman, please go ahead and share with us what you have to tell us about what is the perspective of using these technologies and whatever teach you feel appropriate. Thank you.
Good day to everyone. Good morning from Chicago. Can everyone see my screen?
Yes, go ahead.
Thank you. Today I'm going to be talking about stationary versus portable X-ray machine, their utility and their flexibility. Starting with the introduction, stationary and portable X-ray machine, they both serve a very important role in medical imaging, but each of them have their unique advantages and their limitations. The radiographers that operate this machine, they play a very important role in ensuring and maximizing the utility of this technology in order to meet the clinical demand of the clinicians. Department that uses this machine, they have to ensure that it is adaptable to the diverse healthcare setting. For example, if it's going to be an outpatient, if it's going to be an inpatient, we have to ensure the machine is appropriate for the setting. Just a quick overview of what the machines look like. As mentioned earlier on in our previous presentation, stationary X-ray machine, they are located in a particular place with enough room space. Portable machine, they can be moved from one location to the other. I'm going to be looking at the utility and flexibility of stationary X-ray machine. So here we have a stationary X-ray machine. Like I said earlier on, they are mostly in a particular fixed location. They have more space to perform different exams. It is mostly good for patients who can move around. Here, a patient is being positioned for a chest X-ray. This position is the actual one in which a good chest X-ray can be produced. As you can see, the patient's chest is touching the image receptor. In these instances, we call it posterior anterior because the X radiation is coming in from the back to the front. And this exam is the most performed exam in imaging department. And it can only be done easily when it is done with a stationary machine. This is just a good view of what it looks like with stationary machine. You can see we have here like a standing mounting imaging receptor. We have one lying down. The tube can be moved around easily in this room. This provides a good environment for both the technologies and the patient. One of the benefits of stationary X-ray is the fact that it's easy for use by the technologies. At the same time, patient can be easily positioned. It's very, very important to ensure that when obtaining an image, there has to be room whereby appropriate exam can be done. For example, here, this patient is being positioned for what we call a side view chest X-ray. To appropriately diagnose some health issue, it's good to have two views. The one I showed previously, the PA, and the lateral. Lateral can only be done with a stationary machine easily. And you can see the patient has to raise their hands up. The technology has to position the patient. This can only be done easily with a stationary X-ray equipment. Again, you can see the patient is lying down here. Technology is moving the machine around. It provides a wide range of flexibility for the machine to be moved around, patient to be positioned appropriately for different exams. Again, another image showing a patient being examined for upper extremity, the flexibility that comes with it. I mean, we can see patient is comfortable, technologist is doing his job without too much obstacle to obtain a good image. Here is a young guy here being examined for a lower extremity exam. This is another example of the benefit of stationary X-ray machine. Now I'm going to be looking at flexibility and utility of portable X-ray machine. The portable X-ray machine is the one that can be moved to different locations. It can be moved from one room to another. It is powered by battery. But one thing here is like it has to be plugged after every use because it uses battery. You cannot finish an exam with it and left it without plugging it back. The battery is going to drain, and when it's next for you to use it again, you might not be able to use the equipment. Again, one of the thing with it is like it can be moved around to be used on patients who cannot be transported to stationary X-ray machine. This equipment is good for patients who are very sick, who cannot move around. Portable X-ray machine for patient in emergency room, patient that just went through a trauma, they cannot move them just easily or due to their injury. So portable machine has to be taken to them for them to take the exam. Like this image here is a patient ICU. ICU patient, they have so many tubes attached to them. Moving them from their room to imaging department might be so difficult. And if there is need for an exam to be done, then someone has to go there to take the exam. Also, patients who are isolated, for example, during COVID, we cannot move patients just around in the hospital. And the chest has to be assessed or maybe other exam. So in this instance, they have to take the machine to the patient. Another area that is very highly beneficial is when patient just went through a surgery. Patient that just went through a surgery due to anesthesia, all this stuff, they cannot be moved around easily. Again, portable X-ray to the rescue here also. This just to show an image of portable X-ray being used here. You can see it has to be plugged. The technologies have to move around. This is not something that happens often. You can see the patient can easily sit up by himself. Most of the time, the patient doesn't come easy like this when exam is being done with a portable machine. Now, I'm just going to do a quick little comparison between these two machines, just for us to see where they both play a role and their limitation to a large extent. As I mentioned earlier on, chest X-ray is the most performed exam in the imaging department. Even for patients with TB, chest X-ray is the go-to guy for assessment. The limitation here for portable X-ray is the fact that you cannot position patient to stand up upright. To produce a good image, patient needs to stand up upright with their chest to the image receptor. With portable, you cannot do that. Patient can only position this way. And the difficulty in positioning them goes a long way. Another thing here is like when we're performing chest X-ray, patient has to take a kind of deep inspiration, like take a deep breath in, blow it out. When it is being done with portable, that could create some challenges. Another thing that is very important here is the distance between the machine and the patient. I think it has to be like 72 centimeters. We cannot obtain that when we do portable. So that is another limitation to portable equipment. Another thing is the exposure time. As was mentioned by the medical physicist, there is something called AEC. AEC is not available with portable machine, but we have it with stationary machine. So like when you make exposure, the moment you take your hands off, the exam stops. We don't have that with portable machine. And lastly here, is scatter radiation that was mentioned earlier on. most of the exam performed by portable, we cannot use grid because of the alignment. That is one thing. Another one is the fact that because of the distance, you don't want to be cutting off certain part of the body. And scatter radiation, what it does is like it creates a less quality for the image. So when you do exam with no grids, there's high chance your output is not going to be as the one that we produce with the one we grid. And all the equipment in stationary, they have a grid already inside them. So this is a 2-view chest X-ray that is produced by a stationary X-ray machine. I mean, this is what any radiologist always look forward to see when you produce an exam. This can only be done in the department with stationary machine. You cannot produce anything like this with a portable X-ray machine. Just a quick comparison. This exam here on this side is produced with a stationary equipment, this one with portable. I would like to quickly just highlight 1 or 2 things here. If you look at this image, you can see how green this is. This is due to the fact that the energy produced from portable machine is not as high as the one with stationary exam. And again, the lungs is usually produced in a full view with a stationary machine. We don't get to have that with portable machine. That's just happened to be one of the downside of portable X-ray. In terms of comparing their utility, I mean, as I mentioned earlier on, stationary produce for us a superior image due to their high power and advanced software. We can use it to produce a good exam for different parts of the body at the same time, like upper extremity and forearm, lower extremity, knee, tibia, fibula. We get a good image when we use stationary machine. Portable machine, I mean, it has its own great importance. Like when the patient cannot be moved around, we take the machine to the patient instead of the patient coming to us. But one thing we have to compromise with portable machine is the image quality due to the low power capabilities. For us radiographer, I mean, if you ask us to pick, which machine do we prefer? I mean, everyone will say they prefer stationary machine, but it comes with its own challenges as well. If they are bringing patient from afar, a patient has been scheduled, ICU patient is not feeling very well, this could cause some delay in workflow, especially with critical case patient as mentioned. Portable machine, I mean, pushing the machine from one area to another, that creates some extra stress on the radiographer. And also, when you're positioning with portable, it could create a lot of inconvenience for both radiographer and the patient. One thing that has to be mentioned here, it was a little bit touched on by our medical physicists, is the fact that you cannot really control the radiation safety when it's come to portable. With stationary equipment, the wall area is protected with lead in the wall, but for portable, there's nothing like that. I mean, you go to a room, maybe there are 2 patients in the room and you want to do portable on one, definitely there is high chance of unnecessary radiation exposure for the other patient in the room. This is another area where portable machine create a kind of challenges. I just put this image just for us to see when a radiographer has to perform exam in a patient in a very small area. You can see the technology has to be stretching a hand out just to produce 1 or 2 images. This is another area whereby portable can be a kind of a challenge for both the radiographer and the patient. In conclusion, stationary system, I mean, it produced for us a good image quality, even though portable kind of give us some flexibility of being able to move our machine from one area to the other. And in terms of flexibility, yeah, portable can be moved around. Stationary is in one place, but in terms of being able to perform the exam, being able to produce a high quality images, stationary machine comes out high in this instance. Challenges, I mean, portable machine, like I said, low image quality, and again, power fluctuation can happen. This is something that you don't usually get with stationary machine. Again, this depends on where this is being needed. Both of them has their advantages and disadvantages, but everything being equal, image quality is what is most important here. And so stationary machine produce for us a better image when compared to portable machine. Thank you so much.
No, muchísimas gracias a ti, Suleimán, por refrescarnos también aspectos muy relevantes en el uso de esta tecnología. Creo que solamente por aclarar un par de cosas que a veces la traducción no es sencilla, ¿no? Dada la terminología, ¿no? Que a veces se usa. Bueno, el primer punto es, obviamente, lo que comentabas, el posicionamiento del paciente. Uno puede tener toda la tecnología, puede tener todo el software, puede tener toda la complejidad, pero si uno no realmente no posiciona adecuadamente al paciente, uno no pone bien al paciente y no lo hace adecuadamente, puede tener una imagen que no sirva para el propósito clínico. Y es muy relevante, por tanto, el papel y muy crítico el papel que va a hacer el tecnólogo o el radiógrafo en obtener en conseguir ese objetivo. El otro tema, como comentabas, es el tema de la calidad de imagen de los distintos dispositivos. La traducción hablaba de grid, lo traducía por cuadrícula. Normalmente el término que usamos para los que hablamos en español es o bien la parrilla antidifusora o la rejilla antidifusora. Que los equipos portátiles, eso es un reto y eso hace que la calidad de imagen debido a la radiación dispersa, como bien me explicabas, pueda verse comprometida en algunas circunstancias. Y el otro tema, por supuesto, efectivamente, los retos de seguridad radiológica, pero como también como nos comentaba Benjamin, puede haber opciones de usar los tres elementos, la distancia de las personas que puedas tener en los equipos portátiles e incluso usar bueno, pantallas móviles que puedan reducir la radiación a niveles aceptables. Pero aún así, como bien dices, hay un reto adicional cuando usas equipos portátiles porque no tienes los muros plomados, ¿no? En general, ¿no? Pero bueno, muy bien, muchísimas gracias, Suleimán. Y sin más, pasamos, como digo, al final, por favor, si tienen preguntas, las vamos a pasar al final y podemos intentar interactuar y contestar lo más que podamos. Nuestra tercer panelista, well, I'm gonna switch to English. Last but not least, is Dr. Leah Strickland. Is an assistant professor in the Department of Radiology at the Division of Cardiographic Radiology at Duke University School of Medicine, the North Carolina, US, with expertise in diagnostic radiology and cardiothoracic imaging. Dr. Strickland has contributed to both clinical practice and academic research. So, yeah, sorry, I'm listening in parallel the translation, so that was very confused to me. Okay, so Dr. Leah, please, Dr. Strickland, please go ahead. The floor is yours.
Sorry about that. Thank you for the kind introduction. So I'll be giving, as a radiologist, some clinical insights about the difference between a stationary and portable radiograph unit. So my learning objectives of my talk are to understand the role of imaging and TB control. We'll compare different chest X-ray imaging modalities, stationary and portable units, and then discuss specific clinical applications. So the other speakers have already touched on this, but just as a brief overview, whenever obtaining a chest radiograph, the X-ray machine generates a beam. The beam passes through the patient's body, interacting with tissues such as bones, lungs, and the heart. And then it's detected by the detector, and then we have an image that's formed. The image that's formed is due to differences in absorption of bones, lungs, and the heart. And this creates a 2D representation of 3D anatomic structures. So you're looking at just chest ray. I use the different shades of gray to try to figure out what's going on and diagnose disease. So just to touch on some of the role of chest radiographs in TB screening and triaging of TB. Chest x-rays are very rapid and they're a sensitive tool for detecting TB disease. They can be especially useful if you have cases where patients are asymptomatic. They can assist with determining if there's a need for empiric therapy in suspected cases of TB, along with clinical information, and can reduce the number of people that have to undergo bacteriologic testing. Chest x-rays are also useful for ruling out active TB disease before providing treatment for latent TB. Chest x-rays are a comprehensive diagnostic tool. Oftentimes the main reason for obtaining a chest x-ray is to form a differential diagnosis, since they can identify a range of lung pathologies. There may be another explanation for the patient's symptoms, such as lung cancer or an occupational lung disease. Chest x-rays can also identify coexisting conditions, such as heart failure, emphysema that could complicate management, and in rare cases, identify extrapulmonary TB. So this image here I have on the picture here is just a patient with lung cancer. You can see a large mass, some enlargement of lymph nodes and pleural effusion. So if I saw this picture, the first consideration would be lung cancer. Chest radiographs are also useful for following up patients with known cases of active tuberculosis. They enable assessment of treatment response and can help with determining the length of treatment. In fact, radiographic stability over the course of 6 months is an indicator of inactive disease. Chest x-rays can also aid in identifying complications of tuberculosis, such as pneumothorax, pleural effusion, or hemorrhage. So the image in this slide is someone with treated TB. So this is just evidence of old infection. There are many limitations of chest radiography, unfortunately. The first I've already discussed. It is a 2D image of 3D structures. So interpreting chest radiographs can be very challenging, requires a really high level knowledge of anatomy. There's also low specificity for tuberculosis, since there's a lot of overlap in chest radiograph findings. So even if findings are consistent with pulmonary TB, the same findings can also be seen in other lung pathologies. There's a lot of reader variability, both within and between readers, and so interpretation can vary. There is also a lack of a universally accepted reporting system for TB. And finally, as was previously discussed, patients are exposed to ionizing radiation whenever they receive a chest radiograph. So now to shift gears and just comparing a stationary versus a portable radiograph unit. A lot of this has already been discussed by our previous speakers, but stationary radiographs are going to provide superior image quality. And this is in large part due to just you're better able to more optimally position the patient. One downside, though, of a stationary radiograph unit is it requires patient transport to the radiography suite. Portable units, on the other hand, do have lower image quality, but there is no need for patient transport. So you're able to use them in diverse clinical settings, such as the ICU, the OR, or the emergency department. In fact, I work at a large tertiary care center with lots of sick patients, so more often I'm reading portable radiographs. So just to further dive into the comparison, we have a picture of a patient receiving a stationary radiograph where you're able to get a posterior, anterior, and a lateral view. When I say posterior, anterior, or PA view, what that means is the beam is traveling through the back of the patient to the front to hit the detector. Since the patient is standing upright, you're able to better position them and more easily obtain an image with a really good breath hold. With portable radiograph, most of the time the patient is in a hospital bed. The beam passes from the front to the back of the patient, so we get what is called an anterior-posterior view. Getting additional projections is very challenging. Every once in a while, I've seen we'll attempt to get a lateral view, but it's usually non-diagnostic. So most of the time, you're only getting a single frontal view. So here I have the same patient. These two images were taken a day apart, and you can see the difference in quality between a standard PA radiograph and an AP radiograph. You get much better lung visualization, just able to much more easily pick out fine detail. Also, the representation of the heart and mediastinal anatomy is much more true to real life, where when you get a portable radiograph, since it's an AP view, there is some magnification of these structures. So if I had to choose, I'm always going to prefer to look at a PA chest radiograph because of the superior image quality. Now, other considerations, the positioning of the patient is very important. Now, sometimes portable radiographs are obtained in supine position, which is where the patient is lying on their back. Other times they're partially sitting upright, which is called a semi-erect position. So these are two images where that were obtained with supine position. So first off, you can see how the structures here around the heart are much more ill-defined. So you can get some false enlargement, again, of the heart and the mediastinal structures. Also, the diaphragms tend to be more elevated, which can obscure the lower portions of the lungs. And then we also get this effect called layering. So two potential complications of tuberculosis, which I already mentioned, be pleural effusion or a pneumothorax. That's when fluid or air gets outside the lung. If the patient is on their back because of gravity, this can layer and be much more difficult to visualize. So in this image, there's this diffuse haziness. So it would be easy to misinterpret this as an airspace process, such as a infection, when in fact, all it is fluid layering behind the lungs. So you can see here's a CT that was performed the day before, and you can see how the fluid layers behind the lungs. And when you're getting the image passing through, when the patient is flat, that can be very difficult to interpret. Another important factor is the lung volumes. We've already talked about how it's so important to get a chest radiograph with good inspiratory effort. If a chest radiograph is obtained with patient in expiration, you can have effects like increased lung density. You can see how just the lower portions of the lung appear much more dense. It can be very easy, again, to interpret this as some sort of pathology like an infection. Also, the lower portions of the lungs are less well visualized. And again, this is a common theme with the portable radiography. You get an overestimation of the heart size. So the heart appears falsely enlarged. So here, again, same patient. This was obtained the next day. And you can see the heart is perfectly normal in size and the lungs are clear. Okay. Another factor of patient positioning that can lead to a lot of artifacts is patient rotation. With the stationary unit, it's much more easy to ensure the patient is perfectly aligned. So here's some examples. This might get confusing with radiology. This is radiology right, this is radiology left, so I'm going to go ahead and point that out. But with right-sided rotation, you can get a lot of false enlargement of the heart and mediastinal structures. It would be easy to interpret that there might be some lymph node enlargement on this image, when in fact the heart and the mediastinum are normal. This is just some layering pleural effusions, which I already talked about. Another thing can happen, in this example, the patient is rotated to the left. Here in the lower portion of the chest radiograph, we have this increased density. It's very easy to misinterpret something like this as a pleural effusion or an airspace opacity, when in fact, it's just due to overlapping soft tissues. Finally, if the patient is rotated, you can get asymmetric opacification. So the lung appears more lucent on the right side, radiology right, but more dense on the left side. And this is all due to rotation and is a mimic of pathology. Finally, it's much more easily to have with the portable units because it's so difficult to position the tube relative to the patient. You can get patient angulation. This can cause apparent enlargement of the heart and mediastinum structures and also obscure the lower lungs. And this is just, again, this was the same patient, and you can see the heart looks enlarged, but it's in fact normal in size when we retook the image. Okay. Another thing that's been talked about is the inability with the portable unit to get additional projections. So we have a saying in radiology, 2 views are better than 1. I always like to have more views of a patient because they provide additional information. It's very difficult to get a lateral view with a portable unit. Much easier with stationary radiography. The lateral view provides a lot of helpful additional information when assessing structures in the chest. One thing I wanted to point out, as you can see, because of the position of the diaphragm, when you're getting just a frontal view, there's a large portion of the lower lungs which aren't visualized. I'm just going to briefly talk about some of the radiographic findings of tuberculosis. The case here on the left, if I showed this to one of my trainees, I would expect them to immediately give tuberculosis as a differential. This is kind of a classic look. We have these upper lobe consolidations and nodular opacities with areas of cavitation. There's also a pleural effusion. If you had a case like this, you would be able to easily visualize it with a portable or a stationary unit. However, sometimes the findings can be much more subtle, especially if it's early in disease. Also wanted to point out some atypical presentations of tuberculosis. There is something called Miller disease. What this means is just lots of tiny small nodules the size of sesame seeds throughout the lungs. This is a very severe form of tuberculosis. The findings can be very subtle. So if you don't have a good quality image, this could be easy to miss. Nodal enlargement is also something to consider because of, remember I talked about with portables, all the issues we have with the heart and visualizing the mediastinum. Kind of the soft tissues around the heart is where we look for nodal enlargement. And so if that's not well visualized, you can miss nodal enlargement. This is really important for pediatric cases where that may be the only presentation. So again, I just wanted to highlight some of these special populations that can be more challenging. High-risk groups such as the elderly, immunocompromised, and diabetic patients require special attention since they do present with these atypical presentations. And young children, like under the age of 40, particular focus since they're at higher risk for primary infection, which can present with nodal enlargement, which may be the only finding. So a good quality radiograph is very important to detect atypical or subtle findings. So in a lot of these cases, it's great if they would have, or these high-risk patient populations have access to a standard stationary unit. Also, the additional views can be really helpful for these challenging cases, especially pediatric cases. Nodal enlargement can be much more easily visualized on a lateral view. So finally, in summary, portable units are particularly valuable for expanding outreach in enabling TB detection in more remote or underserved areas. In the hospital setting, they enable bedside imaging of critically ill or immobile patients and can be used in diverse clinical settings such as the operating room or emergency department. However, there are many technical limitations of portables that can compromise diagnostic accuracy. Stationary units are ideal for centralized healthcare facilities since they offer superior quality imaging and give a more comprehensive evaluation. They're optimal for following up cases of tuberculosis since you can assess those subtle changes and establishing good baseline imaging for patients. They're also better able to evaluate for atypical TB presentations and identify complications. Right, thank you very much.
Thank you very much, Dr. Strickland. I think, again, you have also provided with some very valuable information on the perspective of the radiologists and the challenges in order to get the proper images and the challenges that you may find as an interpreter on how to best provide the accurate diagnosis, and also comparing the different diagnoses and the technologies. Perdón, voy a hablar en español ahora para los intérpretes que sepan. Como digo, creo que hemos tenido aquí 3 presentaciones de 3 expertos en diferentes temáticas. Tenemos el equipo completo, digamos, sería el físico médico, tenemos al tecnólogo, tenemos al radiólogo en usar estas tecnologías. El objetivo principal es intentar, bueno, poner sobre la mesa esas consideraciones, esos retos que os podéis encontrar en los países en función de la tecnología que o bien estéis usando o vayáis a usar o tenéis que pensar usar para el futuro. pero creo que es una gran oportunidad ahora si tenéis preguntas específicas, comentarios, retos, que a lo mejor aprovechando la ventaja de que tenemos aquí a tres expertos en diferentes temáticas, puedan ayudar a despejar o aportar. Entonces, no sé las preguntas si las mandáis por el chat, ¿verdad? O cómo funciona. No sé, Belkis, ¿cómo las preguntas, cómo las van a hacer por chat o directamente hablan las personas?
Sí, gracias, Pablo. Sí, vamos a ver las preguntas que están ya en el chat o está en question and answer. Pues vamos a ver, no tenemos preguntas en question and answer, no tenemos todavía en el chat en
Ah,
este
ok.
momento. Vamos a invitar a que las hagan a todos los participantes que han estado durante esta presentación todo el tiempo, que sus preguntas las pueden hacer ahora directamente en el chat o en la sección de preguntas y respuestas. Parece que hay un problema de sonido. Nos escuchan los participantes quizás levantando. Sí, se escucha muy lejos. Se escucha muy lejos. Sí que les invitamos, como decía Pablo, a hacer sus preguntas en este momento. Y pueden hacerla en la sección de preguntas y respuestas que está como question and answer o en el chat, como prefieran hacer sus preguntas.
Bueno, mientras tanto, no sé si creo que el mensaje principal, un poco si me permitirá, es que no hay una solución que va a resolver los problemas para todos, no única solución, sino que hay distintas alternativas y distintos ventajas e inconvenientes o retos en algunos casos. Lo importante es conocerlos, lo importante es saber si uno va a optar por una opción, bueno, pues que es importante tener en cuenta pues no sé, si se usa un equipo portátil que lógicamente puede comprometerse algo la calidad de la imagen, hay un reto de posicionar el paciente, puede haber un reto en el número de pacientes si tiene una carga de trabajo muy elevada, hay que tener una serie de consideraciones para protegerse y proteger a otras personas de la radiación quizá más, etcétera. Hay una serie de elementos que tienes que tener en cuenta. Lo mismo te pasa con si usas un equipo estacionario, pues lógicamente necesitas un centro médico, necesitas etcétera, etcétera. Hay muchos elementos de consideración y eso es un poco lo que pretendemos aportar. No se escucha, me están diciendo la gente, no sé por qué. No se escucha, hay varias personas que no están
Muy bien,
escuchando.
aquí.
Sí, aquí escuchamos bien, se escuchó
Sí,
muy bien y parece que es en la traducción en español.
Sí, sí, tenemos respuestas que se escucha bien
ok.
Los intérpretes sí escuchan.
y la gente también
Ah,
está. Sí.
ok. Hay algunas personas que han tenido algún reto, pero entiendo que la mayoría,
Ya porque únicamente
bien.
es- no.
Bien.
Nosotros vamos en español.
Sí, nosotros acabamos de colocar en español y se escucha muy bien. Se
Ujú.
escucha muy bien. Pueden darle al idioma original en este momento y pasar al español para que comprueben. Ok. Tenemos una pregunta, Pablo. Si quieres, te la
Sí,
leemos.
sí, por favor.
Sí, para que la traducción pueda
Ah,
traducir
claro.
para todos nuestros panelistas. Muchísimas gracias. A nuestro panelista, esta pregunta es de Adriana Chacón. Dice, buen día. Queremos saber si existen estándares internacionales que puedan mostrarse localmente respecto a los requisitos necesarios para el uso de los equipos de rayos X, específicamente, por ejemplo, la certificación CE 60601 y la ISO 13485. Y si un certificado de conformidad total podría cubrir estos dos documentos si no se dispone de los mismos por separado.
Ok, bueno, Benjamin, si quieres puedo ir contestando y si quieres tú luego después complementas un poquito la pregunta. Esto está relacionado, no sé si la traducción lo ha hecho correcto, está relacionado con estándares de producto, ¿eh? Son estándares de fabricación del producto. A ver, todos los productos médicos, cualquier dispositivo médico en general, necesita tener unos criterios de calidad y de seguridad con el objeto de minimizar o de reducir al máximo pues eso, la seguridad para el usuario, normalmente para el paciente, pero también para el usuario, depende del dispositivo médico. En el caso concreto de equipos de rayos X, básicamente los estándares tienden a centrarse en tres grandes bloques. Unos relacionados con los aspectos de seguridad mecánica, es decir, no queremos que un tubo de rayos X nos caiga encima de un paciente, por ejemplo. Hay algunos estándares relacionados con los aspectos de seguridad eléctrica. Tampoco queremos que un paciente o un trabajador tenga un problema eléctrico, ¿no? De seguridad eléctrica, de que se electrocute, por ejemplo, ¿no? Y hay estándares relacionados con aspectos de seguridad radiológica, en función de pues, que tengan pues eso, una serie de elementos de que reduzcan, por ejemplo, como nos explicaba Benjamin en su presentación, la radiación de fuga o el filtrado mínimo que debe tener el ánodo, que nos explicaba, con el objeto de que la radiación que llegue a los pacientes sea la adecuada y la no necesaria, evitarla en la mayor medida posible. Entonces, dentro del panorama internacional están, como bien dice ahí, los certificados, los criterios que establecen los estándares de la Comisión Electrotécnica Internacional, la International Electrotechnical Commission, que son los que son. Las autoridades nacionales, las autoridades reguladoras de equipos médicos nacionales, adoptan eh, o adaptan estos estándares a sus requisitos nacionales. Entonces, en los países donde eso existe, que no en todos, desgraciadamente en América Latina, no en todos tienen eso adaptado, lo que comúnmente se usa es que aceptan los certificados que se usan, por ejemplo, aquí en Estados Unidos, que da la FDA como válido, o bien en Europa el mercado que se llama mercado CE, el mercado CE. Eso sería un poco el equivalente o el certificado de conformidad que normalmente aceptan a la mayoría de los países de América Latina. Hay algunos países, como digo, no obstante, que tienen sus propios normativas nacionales. Entonces, si, por ejemplo, en Argentina o en Brasil o en México, yo sugeriría que verifiquen qué es lo que tiene a nivel nacional, por ejemplo, ANMAT en Argentina, ANVISA en Brasil o la COFEPRIS en México, ¿no? Pero digamos, eso es un poco el panorama. No sé si me he extendido mucho, perdón, pero no sé. Benjamin, I don't know if you want to add something or I forgot something.
Um, I don't think I have anything to add. I only have experience working with the FDA, so yeah,
Okay.
I don't know very much about the international, unfortunately. Thank you.
Bueno, entonces sería un poco la. No sé, ¿hay otra pregunta más, Belkis?
Sí, tenemos otra consulta. Tenemos de Regina Plaza, que dice: buen día, el uso del portátil afecta el desempeño de los sistemas diagnósticos asistidos por computadora para la detección de TB. El uso del portátil afecta el desempeño de los CAP, de los software de inteligencia artificial utilizados para la detección de TB. Si tienen alguna información. El tema de los portátiles estamos hablando que todos generan una imagen y la inteligencia artificial va a leer la imagen, una imagen tipo DICOM. Entonces, no sé si alguno de los panelistas quiera responder esta
No
pregunta.
sé, yo puedo dar una primera respuesta, pero obviamente los colegas pueden completar o. A ver, obviamente el software es una herramienta muy importante y muy poderosa, pero lógicamente su efectividad va a depender de la calidad de la imagen que uno le introduce, ¿no? Si la imagen que uno introduce no es muy buena, pues lógicamente el software va a tener mayores problemas a la hora de funcionar, ¿no? Entonces, por ejemplo, la experiencia que reportaban en algunos países es que hay retos en algunos portátiles con la calidad de imagen y hace que el porcentaje de falsos positivos sea mayor. De tal manera que sí que hay alguna relación entre la calidad de imagen y lo que el software puede haber. pero es una información muy vaga en el sentido de que no podría decir exactamente cuánto, porque hay que medir. Pero digamos, la respuesta en corto sería sí, sí que es relevante la calidad de imagen a la hora de que el software pueda funcionar adecuadamente o en la manera más óptima. No sé, alguno de los colegas, no sé, Benjamin o Leah o anyone would like to add something or some comment on that point?
I could comment. I have not
Yeah.
used specifically any of the AI algorithms for TB detection, but I have experience using some for other radiographic abnormalities like pulmonary embolus. And it's interesting that the AI does tend to get confused in the same way that a human reader may get confused. So that's important to keep in mind. I showed like some of the artifacts can be produced by portable radiographs. So that's been my experience in using some of these AI algorithms.
Okay, thank you, Leah. Yeah, that's the thing, you know. If you have artifacts and the image is not well done, or the position is not right, or you don't have enough contrast, or what you're looking for, the software cannot make miracles. That's the short answer. Yeah. Thank you. Otra pregunta, Belkis, quizá.
Sí, quizás preguntarle a Denis si tiene alguna opinión respecto a esta pregunta que se ha hecho sobre el uso de inteligencia artificial. Denis, sobre el uso de la inteligencia artificial en los...
Yeah.
Sí.
Yeah, so I typed my answer actually to the question. It's a very good question, and we're getting this question. But the evidence that we had reviewed in 2021 did not include, was not coming from portable machines, so and ultra portable machines. So, however, there have been some attempts to like look at this, like quite anecdotal, to check the comparability between this, and it seems to be comparable. But I don't have like a sort of an evidence base to cite for this. But it is encouraging that the quality is sufficient to be able to discern the abnormalities that would usually be detected on more stationary or less sort of bigger machines. Thanks.
That's a good point. Thank you. Okay. Otra pregunta, quizá.
Sí.
Carlos Carlos,
Sí. Tenemos la pregunta de Carlos Garner. Tenemos el uso de equipos portátiles cuya exposición a radiación es mayor que protección debe tener el personal en cuanto al tiempo de exposición.
Maybe Benjamin, you would like to add this one, answer this one?
So for the portable x-rays,
Yeah.
after the technologist sets up, while they're holding the switch, they should go as far away as they can from the x-ray machine and the patient. And then it could be good to wear an apron, a leaded apron. Yeah.
Por supuesto. Y también si puede haber otras personas cerca, procurar ver que las personas, no haya otras personas cerca en lo posible. Obviamente si estás en un lugar donde no hay manera, pues no hay forma. Pero si es posible evitar también que otras personas estén por el tema de la radiación dispersa, ¿no? Sobre todo, no vas. Obviamente, por favor, que nadie use radiación directa contra otra persona que no sea el paciente. Eso es fundamental, ¿no? Otra pregunta. ¿Ah?
Sí, tenemos una pregunta de Ramón Castillo. Nos dice, ¿podrían comentar si con las nuevas tecnologías disminuye el riesgo del uso de radiografía en pacientes embarazadas?
Anyone? Yo no tengo, sí, okay, go ahead.
I can comment on this.
Yeah.
Using radiography to get a chest x-ray of a pregnant patient is a very low risk of hurting the pregnancy. We should avoid it, but it's a very low risk to the fetus, to the child inside the mother. As far as new technologies, there are some new x-ray systems who propose that their image processing is so good that they can use less radiation. I've been in 2 clinics that tried these new technologies, and their images were not good. So we don't think that new technologies for processing will change how much radiation we need to use, and so this probably will not change in the future. That's my opinion. Yeah.
Okay. Gracias, gracias, Benjamin. Pero vamos, el mensaje es que efectivamente para una exploración de tórax, la cantidad de radiación que puede recibir una mujer en el útero es relativamente muy baja, ¿eh? Eso es el mensaje que hay detrás. Obviamente, si puede evitarse, mejor evitarla, ¿eh? Pero si es prescindible por una cuestión de emergencia médica de la persona, pues hay que hacerle la exploración, ¿eh? Gracias por el tema del software. Tampoco tengo yo claro que pueda o no modificar enormemente la cantidad de radiación que pueda recibir en útero, aunque lógicamente todo evoluciona en que los detectores cada vez son mejores, etcétera, etcétera, ¿no? Pero eh, es lo que hay. Otra pregunta entonces, Belkis.
Luego la de la inteligencia.
Lo del CAT, si quieres
Sí.
digitalizar y que se...
Sí. Otra pregunta es de José Olinde. Buen día. ¿Es posible adaptar el software CAP más inteligencia artificial a un equipo de radiografía convencional? Muchas gracias. Si el equipo, me corrige Pablo, si el equipo es digital, aunque sea fijo, porque el equipo convencional puede ser digital y podemos tener imágenes en DICOM, se puede leer por cualquier sistema de CAD. No, Pablo, por favor.
Sí, ok, estamos hablando de equipos, por ejemplo, que están basados con película, entiendo, ¿no? Y uno pues, puede digitalizarla, puede tener, añadir una radiografía, una tecnología que se llama CR, de tal manera que puede digitalizarse. Una vez que está digitalizada, el software puede ser alimentado. Sería un poco la pregunta corta, ¿no? Si he entendido bien. Esa es la respuesta corta, si entendí bien, ¿no?
Sí, la hacemos entonces. Sí, sí, sí. Tenemos otra pregunta, Pablo, de un anónimo. Dice, en los países sudamericanos utilizan mucho la radiografía de tórax para la detección de TB. Se mencionó que su uso para TB es de muy baja sensibilidad. Esto me llama la atención o está relacionado con la prevalencia. Debe haber probablemente una confusión en la traducción porque la
Yo creo que
radiografía es
sí,
de alta sensibilidad.
exacto.
No, es un poco de baja especificidad, pero de alta sensibilidad. ¿Cambio, Pablo?
Sí, yo creo que sí. Lea puede complementar, pero creo que puede haber habido un tema de interpretación. Efectivamente, alta sensibilidad, baja especificidad. Lea, por favor, si quieres complementar.
En las vías del 2021.
Yes, test X-rays are high sensitivity since they're going to detect any like lung abnormality, but the specificity is low since there's a lot of overlap between different lung diseases can appear similar. So that is correct. So yeah, I think the sensitivity of chest, I can't remember the citation I used, but combined with like clinical assessment and chest X-ray, I think it's one of the highly sensitive screening tools that we have.
Gracias,
Muy bien.
Pablo.
Sí,
Y
sí,
así solo para comentar sobre
sí.
eso, ¿no? Justamente en las guías que hacía referencia antes Denis del 2021 de screening, de tamizaje, de búsqueda activa, de tuberculosis en las poblaciones más vulnerables, en la comparación de la sensibilidad de las distintas herramientas que podríamos utilizar para el tamizaje, hablando de los síntomas, de la tos, el tema de radiografía. La radiografía es la herramienta más sensible para el tamizaje de la tuberculosis, ¿no? Y por eso estamos promocionando su uso en las poblaciones más vulnerables, en las zonas de mayor alta carga, por esa mayor sensibilidad que tiene frente a las otras herramientas que tenemos para el screening. Cambio.
Correcto. Gracias, Pedro. Sí, sí, efectivamente.
Sí, sí, sí. Tenemos otra
Yes, I think
pregunta.
that's correct. Yeah. I think that's one of the X-ray remains one of the most important screening tools that we have. It's hopefully there will be technologies that are more easy to conduct, right? For screening, even for self-testing in patients. But for the time being, I mean, X-ray, and that's the importance of having X-rays that can get closer to people, like ultra portables.
Thank you, Denise. Ok, muy bien. Belkis, no sé si hay alguna pregunta más, que no sigo todas.
Sí, hay unas preguntas y hay unas solicitudes que vamos a compartir el enlace para ver algunas los webinars anteriores donde presentamos las experiencias de los países en el uso de radiografía ultra portátil, que es la que están utilizando. Recuerden Perú, Paraguay, que tuvimos un webinar. Vamos a compartir ahora el enlace nuevamente para que puedan ver esas grabaciones. Para José Castaño, que ha pedido alguna experiencia en el uso de radiografía ultraportátiles en poblaciones de riesgo como VIH, Ciudad de Libertad y Adicciones. Vamos a mirar esos webinars, le vamos a compartir el enlace para que lo puedan mirar. Hay experiencia en la región, se está expandiendo en estas poblaciones justamente porque podemos mejorar el acceso a poblaciones donde están en zonas rurales de difícil acceso, como los privados de libertad y como las personas viviendo en zonas de calle, homeless y otros grupos vulnerables. En VIH, que acuden a los servicios de salud, hay experiencia en búsqueda activa dentro de los servicios de salud. En cuanto a la pregunta que nos hace Dani Martin, dice, ¿nos podrían compartir experiencia de portátil en niños? Es una herramienta de tamizaje sumamente sensible también para los niños, nos pueden ayudar nuestros panelistas. Sin embargo, en este momento se está validando el uso de inteligencia artificial en niños, que es lo que no se ha validado, pero la radiografía sigue siendo una herramienta de tamizaje altamente sensible para adultos y niños también. Me pueden corregir los panelistas al respecto en la experiencia en niños de uso de radiografía portátil. Sí.
De sensibilidad.
Sí, ok. Bien, ok. Creo que
No
ya
sé,
está la pregunta de Lourdes contestada. Pablo.
No, es el tema del uso en general, el uso de radiografía en niños. Obviamente, lo más quizás relevante es el tema de adaptar la exploración al tamaño del paciente, es quizás lo más relevante. Y tener en cuenta que normalmente para niños, sobre todo niños de menos pequeños, de un cuerpo pequeño, 5 años o menos, no sé, depende. El uso de lo que hablábamos antes, de la rejilla antidifusora, puede no ser una ventaja, aunque parezca en este caso, porque bueno, los niños tienen la dispersión es menor y entonces a veces es mejor no usar la rejilla antidifusora, aunque pueda modificarse un poco las dosis de radiación, pero es relevante adaptar, digamos, la exploración al cuerpo que estamos explorando, es muy, muy relevante. Pero experiencia no sabría decir lo que tú decías, Pelkin, no sé exactamente muy bien cómo para la parte de cribado de tuberculosis. No. Yes.
Yes, we do use portable machine to do X-ray for patients, even neonates. So what is very important there is to reduce the technique. We cannot use same technique we use for adult for pediatric. So they have to reduce the KVP and the mass, and they have to colliminate tightly to ensure unnecessary radiation to other part of the body. So we do use portable machine on patients from age of 1 day old up to 12 years old and above. So portable machine can be used on babies.
Thank you so much, Sulan. Sí, responder a la pregunta de Garner. Todos los webinars de esta serie, este es el quinto webinar, están disponibles en el enlace que le vamos a compartir. Este está en el enlace de la iniciativa regional para la implementación de la innovación hacia la eliminación del TB. Todos estos webinars están disponibles en la página web y además todas las presentaciones, por si la quieren descargar, está en el enlace en Google Drive, que está disponible para todos y lo vamos a compartir ahora mismo otra vez para que lo tengan disponible. Tenemos otra pregunta de Lourdes Gutiérrez, Pablo, que dice: ¿existe diferencia de la sensibilidad entre los aparatos fijos y portátiles para la detección de TB?
Creo que, maybe Denis puede corregir, pero creo que en las guías de OMS, en esas tablas que hicieron en su momento, hay unas ligeras diferencias, pero creo que no son muy diferentes. Hay algunas diferencias, quiero recordar que en algún momento lo vi, pero a lo mejor Denis puede, si la recuerda los números, si no en la guía se puede mandar el enlace y pueden ver directamente los valores que hay. Aunque lógicamente estos temas hay que tener en cuenta de que uno hace estudios en unos entornos que a veces los pasa a otros entornos y no necesariamente las sensibilidades te van a salir iguales, porque hay otros, como hemos visto, hay muchos factores que van a afectar a que los softwares funcionen mejor o peor, ¿no? Pero bueno, no sé, perdón, no sé si tenéis está ahí, a lo mejor recuerda, hay una tabla, quiero recordar, donde comparaba las sensibilidades de las distintas tecnologías y las especificidades, pero el número no recuerdo exactamente. En la guía
Okay, so
de...
we're talking about chest X-ray in general here, right?
Yes, yes.
Not
I
the
think
CAT,
in the
not the
guidelines, I
CAT.
think in the 2021, there is maybe, yeah,
Yeah, so
okay,
maybe I
here we
can
are.
share this
Yeah,
slide.
exactly. Yeah, that, yeah,
Gives you an
okay.
idea about the relative sensitivities here. So you can see that for chest X-ray, you're at about 94% if you're considering all abnormalities, right? And then it goes down to about 85% sensitivity if you're looking for sensitivity, so something more suggestive of TB. And you can see an inverse then in the specificity, right? As Leah was mentioning, right? That if you become a bit more sort of discriminant in the abnormality that you consider, then the specificity will increase, but sensitivity will go down.
Right, right. And I think
Does this
maybe,
answer your question,
yeah.
or
Yes, yes, this is one part. And the other part, maybe trying to remember, maybe it's in the one of the publication by Stop TB partnership uh, with uh, ah, there is a guideline. I think they compare in some publication. I forgot where. I think it's in the one. Uh,
what do you want to compare exactly? So I remember. Maybe I remember.
the different technologies, you know, the ultra portable, stationary.
Oh, I see.
Yeah.
Okay. No, I don't have that here because
I
we are
think
not.
yeah, but the thing yeah, one is done by Fine together with the stock partnership. I think they compare that table, but again,
Okay. I
in
think
certain
I remember
environment.
the document. Maybe
Yeah,
I'll try to find the document and
yeah,
send the
yeah,
link.
yeah. Thanks.
Sí, eso
Okay.
fue lo que lo
Yeah. Vamos a intentar buscar el enlace y lo ponemos en el chat, Belkis.
Okay.
If I could, I just wanted to point out something like this. When you do studies like that, it's under idealized condition, but when like the real like clinical setting, the skill of the technologist, the condition of the patient population can really affect like the quality of the result that you get. So that's just something to keep in mind.
Exactly, yeah. But again, I mean, you have like a starting point, but we already mentioned there are many factors that will affect the ultimate outcome or the sensibility, etc., etc. So yeah, keep that in mind. Yeah.
Sí. Then Denny, you share your screen.
Sí, está buscando la línea. Es que la tenemos en la página. Aquí.
Sí,
No,
está en
but, yeah. But maybe podemos continuar quizá, Belkis, si hay alguna pregunta más.
sí.
Mientras tanto.
Clara lo 50% de casos diagnosticados por expertos en síntomas. Tenían alteraciones en radiografía.
Bien, sí. Con respecto a la herramienta de tamizaje que es la radiología, ahí como presentó Denis, la sensibilidad es sumamente alta y tenemos resultados cuando vean puedan mirar de nuevo el webinar de las experiencias de los países, van a ver que más del 50% de los pacientes que fueron tamizados en búsqueda activa con radiología no tenían síntomas. Lograron detectarlo precozmente, mucho antes de desarrollar los síntomas, y eso es una de las virtudes que tiene la radiología, poder hacer ese screening en esas poblaciones de difícil acceso con los ultraportátiles, pero en las poblaciones también de riesgo que van a los centros con nuestros equipos fijos. O sea, que es utilizar todas las modalidades de equipo para diferentes poblaciones. Como decía Pablo, no hay una opción única, es para tener una gama de opciones. La idea es poder de hacer búsqueda activa de tuberculosis dentro del servicio de salud y llevar el diagnóstico a las poblaciones de difícil acceso. Básicamente, quizás esto resuma todos los esfuerzos que estamos haciendo por entender esta radiología, esta herramienta que es sumamente sensible y que está recomendada desde el 2021 y que Denis está presentando esta guía de implementación que se desarrolló en coordinación con OMS FINE para este uso de la radiografía y el uso de la inteligencia artificial que vino para ayudarnos a hacer diagnóstico porque nos permite hacer el diagnóstico rápido en este momento, en estas jornadas de búsqueda, podemos hacer el diagnóstico con el paciente, el tamizaje para hacer el diagnóstico luego con el paciente de manera rápida, que era lo que nos decía Isa Barahona de Mosca, que los diagnósticos radiológicos son tardíos, por eso está la recomendación es radiografía más CAT, para tener una imagen que nos pueda subjetiva de tuberculosis y hacer todo el paquete de acciones para el diagnóstico de tuberculosis de manera oportuna. Y por eso se ha demostrado que podemos hacer diagnósticos mucho más oportunos, incluso en etapa subclínica, en la mayoría de estos pacientes, en esas experiencias que ustedes van a ver en el webinar número 2 de esta serie. No sé, Pablo, si tienen algún comentario. Me han pedido acercar el micrófono.
Sí, no, no sé si alguien tiene un comentario sobre este tema. Yo creo que esta parte está bastante clara, ¿no? Es decir, ahí lo que acabas de comentar, ¿no? Lo voy a repetir otra vez. ¿Pero algún comentario adicional? Estamos intentando buscar de todas maneras lo que les decía, la guía, no sé, por ahora estoy como con 4 pantallas, me imagino que estamos todos. En el momento que tengamos, pues la vamos a poner en el chat. ¿Mm?
Sí. Yo me encargo de colocarla, nosotros vamos a colocarla en el Drive para que puedan descargarla en el mismo enlace donde están los 5 webinars. Vamos a ir colocando también esos documentos. También están disponibles en nuestra página de la iniciativa. O sea, estamos colocando casi todos los documentos tanto en la página web como en el Google Drive para que todos tengan acceso.
Exacto.
Creo que ya no hay más preguntas. Gracias por sus preguntas. Dejo entonces a Pablo y a Pedro.
Bueno, no sé, quizá yo unas palabras y luego Pedro, tú cierras el... Yo lo primero, por supuesto, es agradecer a todos ustedes por haber participado, por seguir trabajando y por hacer todo lo posible por conocer mejor, ¿no? Las posibilidades, las herramientas, las estrategias, que lógicamente al final son ustedes los que van a ver y conocer mejor el enlace la situación local, ¿no? De lo que está ahí. También, por supuesto, quiero agradecer a nuestros panelistas de hoy que están dedicando su tiempo en conocer, en aportar, en apoyar y en colaborar con esta importante iniciativa que es la eliminación de la tuberculosis, en este caso en las Américas, pero es un esfuerzo global. Es importante, entonces queremos agradecerle mucho, como digo, compartir su conocimiento con todos nosotros. Y también no quiero olvidar, y ahora que veo a mi colega Caiba Medlen, que ha trabajado muchísimo también para conseguir que este webinario sea posible y está siempre con nosotros. Caiba se va a introducir, yo creo que la conocen de otros webinarios, pero por si acaso no, la voy a pasar la palabra que está pidiendo y que se presente y que nos intervenga y nos comparta un poco también su punto de vista. Caiba, por favor.
Thank you, Pablo, and thank you to our speakers. I did want to mention there was a question for Pedro from Odette Wills, who was asking if TB control was on track in the Americas by 2030, and if not, so do you think that the Americas are on track to eliminate TB by 2030? If not, then when? I just wanted to make sure Pedro had an opportunity to also answer question.
Oh, okay. But by the way, could you introduce yourself since I don't know, they already know you.
Yes,
Yeah.
I apologize. Hi, everybody. My name is Dr. Kaiba Medlen. I have the honor of working with Pablo. I've worked with Pablo for years, and I had a background in radiology technology. So it's been very good to work with Pablo because he's a medical physicist and I am a technologist. So we've been really able to work together as a team. So it's also been an honor to work with TB, with Pedro and Belkis. And thank you so much to our speakers and everybody else.
Okay, thank you, Kaiba. Bueno, no sé, entonces le pasamos la palabra a Pedro para, bueno, no sé, algunas palabras finales no sé si puede hablar sobre esta pregunta que decía Kaiba, que se quedó por ahí por el chat, alguna actualización. Pedro.
Perfecto, no, muchísimas gracias, Pablo, y gracias, Caiba. Bueno, gracias, Odette, por la pregunta. Creo que es una pregunta muy importante. Hace algunas semanas la OMS ha publicado el nuevo informe mundial sobre la tuberculosis con los datos que tenemos de cómo está avanzando la epidemia y la respuesta a nivel mundial. Son datos disponibles hasta el 2023 y lamentablemente para la región de las Américas seguimos viendo que no estamos on track, que no estamos en la dirección correcta para alcanzar como región la eliminación de la tuberculosis, ¿no? El impacto de la pandemia del COVID todavía lo podemos ver, la incidencia, el número de casos de tuberculosis en la región sigue aumentando, por supuesto no en todos los países, pero sí en países que aportan más casos todavía vemos ese aumento y afortunadamente lo que sí vemos es que las muertes por tuberculosis estimadas empiezan a disminuir, ¿no? Desde el inicio de la pandemia del COVID, las muertes por tuberculosis han estado aumentando de forma importante. De hecho, éramos una de las regiones que más estaba aumentando, pero afortunadamente empieza a disminuir. Esto nos habla que bueno, va a ser complejo alcanzar las metas que tenemos del fin de la TB para el 2030, pero no es imposible, ¿no? Yo creo que el mensaje importante es que todavía tenemos muchas herramientas, innovaciones, tecnologías, estrategias innovadoras que nos pueden ayudar a acelerar la respuesta a la tuberculosis, ¿no? Y un claro ejemplo es lo que estamos viendo hoy, cómo la radiografía se reposiciona con un papel muy importante para el tamizaje, para la búsqueda activa de la tuberculosis y que afortunadamente tenemos herramientas, tenemos equipos de rayos X, como hemos visto, estacionarios, portátiles, incluso ultraportátiles, que podemos llevar hasta las poblaciones más alejadas, a las poblaciones de difícil acceso, pero que también tenemos esos software de inteligencia artificial que nos pueden ayudar en ese proceso de detectar la tuberculosis presuntiva en la radiografía, ¿no? Por supuesto, tenemos otras tecnologías, otras innovaciones que desde la OPS estamos trabajando con los países de la región para acelerar su implementación y que nos pueden ayudar a acelerar la respuesta y alcanzar las metas del fin de la TB. Tenemos las pruebas moleculares rápidas para el diagnóstico de la tuberculosis y también tenemos nuevos esquemas de tratamiento acortados, más eficaces, más cómodos, que también pueden permitirnos mejorar los resultados del tratamiento, ¿no? Entonces, en resumen, estamos en una posición complicada para alcanzarlo, pero creo que hay esperanza en el sentido de que todavía tenemos mucho espacio, muchas oportunidades de mejora con las tecnologías que ya están diseñadas, inventadas, probadas, de eficacia comprobada, respaldadas por la evidencia de las guías de OMS, que nos pueden ayudar a encontrar antes las personas con tuberculosis, a diagnosticarlas más rápido y a tratarlas mejor, ¿no? Y todo eso también sabemos que puesto en el marco de una respuesta multisectorial que pueda abordar de una forma más amplia los determinantes sociales que impactan en la epidemia. Yo eso para dar respuesta a esa pregunta tan importante y ya para el cierre me gustaría unirme a los agradecimientos que realizaba Pablo, por supuesto a nuestros panelistas, al doctor Benjamin, a Suleiman, a la doctora Lía, por compartir todas estas experiencias, todo este conocimiento, por su tiempo para estar aquí, pero también agradecer, por supuesto, a Pablo por la iniciativa para tener el webinar de hoy, agradecer a Cayiba por toda la coordinación, por todos los esfuerzos y por supuesto al equipo de tuberculosis, a Belkis, a Francisco y también a las colegas intérpretes que hacen posible que podamos difundir todo este conocimiento. Hemos visto en las presentaciones, yo creo que conceptos muy importantes generales de radiología, de protección radiológica, las diferencias entre esos tipos de equipos y solo los mensajes a recordar que la radiografía es una de las herramientas, la herramienta con mayor sensibilidad que estamos tratando para la detección de tuberculosis, que estamos tratando de expandir su uso para la búsqueda activa, para el tamizaje sistemático en esas poblaciones que sabemos que están más afectadas, que son más vulnerables a la tuberculosis y que sabemos que en las regiones donde se está concentrando cada vez más la tuberculosis. Entonces, hemos visto que tenemos diferentes tecnologías, diferentes características, diferentes cualidades, pero afortunadamente un espectro de tecnología que podemos utilizar en diferentes escenarios, ¿no? Desde los equipos estacionarios que pueden ser muy útiles en hospitales o en servicios que están más preparados para tener estos equipos, pero que también tienen mejor calidad y que pueden ser más útiles en el proceso de apoyo al diagnóstico de otras patologías. Pero tenemos los equipos portátiles y los ultraportátiles que, como veíamos, también son útiles en esos servicios en los que quizá no tenemos todos los requisitos necesarios o incluso para utilizar en la comunidad, ¿no? Como decíamos, para llegar a esas poblaciones de más difícil acceso y que sabemos que esos equipos ultraportátiles también tienen calidad suficiente para ser leídos por los software de inteligencia artificial, pero quizá más limitaciones en cuanto a ampliar su uso a otras patologías más allá de la tuberculosis. Todos tienen su indicación, ventajas y desventajas que hemos estado revisando y solo ya recordar eso, ¿no? Que estamos trabajando también con los países para que sigan analizando cuál es esa capacidad instalada que tienen en el país en cuanto a equipos de rayos X, los que ya existen, pero también qué necesitarían para poder expandir la búsqueda activa de tuberculosis con radiografía, ¿no? Y que esto les permita planificar cuáles son esas necesidades para la expansión y que puedan tener en cuenta todo lo que hemos discutido para ver qué equipos son los que necesitan. Ya solo recordar que hemos dicho, vamos a compartir las grabaciones, las vamos a colocar en la página web que hemos compartido, pero también vamos a difundirlas con todos los asistentes. También en la página web pueden encontrar otros materiales relacionados con los temas que estamos tratando de búsqueda activa y también les informaremos sobre las siguientes fechas de los siguientes webinars que vamos a tener sobre el tema de búsqueda activa y también de tratamiento preventivo. Sabemos que todavía hay muchas preguntas desde los países, también con el tema de los software de inteligencia artificial, pero también queríamos tratar algunos temas de monitoreo, de análisis de la información que obtenemos de estas estrategias de búsqueda activa, y recordar que desde la OPS, desde el equipo de tuberculosis y también de los colegas del equipo de salud radiológica, estamos disponibles para seguir aprovechando. Y un último de los agradecimientos que también quería unir al equipo de OPS, pero también al equipo de OMS, que hoy está con nosotros el doctor Denis de Ginebra, del Programa Mundial de Tuberculosis, que nos han estado apoyando en todos estos webinars y en todos los temas relacionados con la búsqueda activa y tratamiento preventivo. Yo con esto me despido y vamos a cerrar el webinar de hoy. De nuevo, muchas gracias a todos. Deseamos que tengan muy buen día. Seguimos en contacto.